Hello, my name is Tegan Thurston, and I'm actually a bioengineering student from Oregon State University, and today I'll be presenting research done in conjunction with Oregon Health and Science University on the assessment of muscle activity and fatigue during laparoscopic surgery. So there are no disclosures needed for this presentation. To begin, it's very well known that surgeons have both high caseloads and high workloads. This includes standing for hours on end and moving from one case to the next with very little or no breaks. And this makes itself known in astonishing ways, where 87% of general surgeons report some form of occupational injury. The reason why surgery tends to be very physically strenuous is because it has static positioning, and you don't generally have a natural posture while you're performing it. This also means that as surgeons move along in their career and their caseloads increase, they tend to also undergo greater musculoskeletal stress. So here are results from a survey asking surgeons where the most painful reported muscle areas are, and unsurprisingly, they're in the neck, shoulders, and all across the back. Now, one of the best ways to pinpoint where these problems occur is to evaluate surgical posture from an ergonomic perspective. However, there are some large research gaps specifically with regards to surgery. The first being that objective approaches for evaluations are really sparse in real-time operation. They're generally done in virtual environments, but this is obviously not equivalent. The time constraints and the mental workload are just simply not the same. And this is done to prioritize patient safety and not distract the surgeon while trying to collect data while the operation is ongoing. Therefore, the most common method for ergonomic evaluation are subjective approaches, asking surveys and questionnaires of the surgeons after they perform surgery. Therefore, one of the two main goals of this study was to objectively assess surgeon workload during live surgical procedures. The next objective was to investigate workload between experience levels, to kind of get an idea of how a surgeon's muscle use may change throughout the course of their career. And we did this by using these Delcis Trigno wireless EMG sensors, and this allowed us to take EMG data from surgeons without going anywhere near the operating table. So we recruited 4 surgeons from Oregon Health and Science University, 2 attending and 2 fellow surgeons. Our independent variable for this experiment was the experience level of the surgeons, where we denoted the attending surgeons as high experience and the fellow surgeons as low experience. Our dependent variable was the percent reference voluntary contraction, or percent RVC. And this is essentially a baseline comparing the surgeon's own baseline EMG value to the average EMG value over the course of the surgery. So the RVC, the reference voluntary contraction, was taken by asking them to perform simple movements to activate those muscles prior to the surgery. So like this one, where we asked them to put their hands behind their head and just push back. This activated their neck muscles, and we used that as a baseline to compare the surgical values with. We took measurements from 10 different muscle groups: the bilateral neck, shoulders, biceps, triceps, and lower back. What we then did for the data collection was we attached these EMG sensors using medical grade adhesive to the surgeons. We took the RVC collection, and then they would immediately start their surgery. And then over the course of the surgery, we took EMG data collections for every 10 minutes for 10 seconds, and then the surgery concluded. Then we took these by muscle group and compared them between the high and low experience level surgeons. This gives us a snapshot of what muscles are used the most during the surgery, and can also give a prediction for what muscles are most prone to fatigue. Obviously, the most glaring difference is in the lower backs, where the low experience surgeons had significantly higher back muscle activity. What we concluded from this is that high experience surgeons likely utilize their muscles more efficiently. This same phenomenon was actually observed in piano players, actually. So professional piano players were found to have lower muscle activity, and this is thought to be they figured out ways, or they learned ways, to cut out unnecessary muscle use. This also means that low experience surgeons are more likely to fatigue in the back muscles. And we suggest that to offset this difference between the experience levels is to implement surgical training methods with ergonomic considerations in mind. In other words, learn good habits early. Obviously, there's a lot of future studies that could be done with this, and that would be to investigate additional factors that may contribute to these muscle use differences. For instance, we only looked at laparoscopic fellows. What if you looked at, say, orthopedic fellows? What would be the muscle use difference then? And then obviously, the major limitation of this study was it was a rather small sample size. We would also like to evaluate over longer periods of time, not just over a single surgery, perhaps looking over the course of a month or a year, what surgeons may experience. So to conclude, it's very well known that surgeons have high physical demands, and this is a major contribution to the musculoskeletal stress that they tend to experience later on in their careers. So using an objective approach for evaluation, we determined that high experienced surgeons have lower muscle activity, and this is likely due to them having more experience, and that low experienced surgeons are more at risk for fatigue, specifically in the back muscles. Lastly, we strongly suggest that there should be a development of ergonomic interventions to reduce the risk of fatigue in surgical training programs. I'd like to thank SAGES for allowing us to present our research. Any questions?